Okay. Yeah, thank you for having me here. My topic is design considerations for anatomical total shoulder arthroplasty. So, for a modern anatomical total shoulder, these are the principles that the prosthesis is designed on. It should be implanted in a patient who has an intact rotator cuff. Reconstruction of the tuberosity in a fracture case is a must if possible. Bone preservation of the as much as preservation, the better. Minimization of stress shielding, reduction of bone resection in a stem prosthesis to improve fixation, and simplifying the prosthesis design for proximal humerus deformity. So for the anatomical shoulder, these are our implant choices. Either it's a long stem, short stem, now stemlesses, resurfacing implants, and for fracture stems, for fracture cases to pass sutures for the tuberosity. On the glenoid side, before we make our choices, we need to be aware of this Walsh classification of for glenoid deformities post in arthritic cases. We'll discuss about that. So let's take on resurfacing. And in for resurfacing and stemless designs, what was their ideology? The ideology is to uh, preserve as much bone. Revisions are easier and easier to take them out. And also in special cases like where there is a plate put in, which is going to be difficult to pass a stem, or in proximal humerus deformities, is where these implants really show their value. So resurfacing was started by Copeland in 1979. The first implant he placed in 86. It it has all the advantages of bone preservation, decreased bone loss, improved range of motion. It preserves humeral anatomy, and diaphysis is not disturbed. But there is a technical limitation. When you're resurfacing the humeral head, you're not taking a humeral head cut at all. And you're just reaming the humeral head, taking away the cartilage. The downside of this is the problem that you have difficulty accessing the glenoid. So on the glenoid side, if you want to do a ream and run or place a glenoid prosthesis, that is difficult. But of late, there are some modifications where you have angled reamers and it's still possible to do it. But most of the times with the resurfacing, hemis are the only possibility. It becomes difficult to do a total. So why do a total shoulder at all? Why not just a hemiarthroplasty? Is because Copeland and Levy they themselves published that patients who had a total shoulder replacement had better constant scores and better range of motion, reduced pain. Uh, but again, in 2010, they came up with Copeland came up with his technique of doing or his revised paper that he said that most of his total shoulders failed, like the glenoid side failed, and which is why he now prefers to do just a hemiarthroplasty. But the most common cause of failure in hemiarthroplasty is painful erosion of the glenoid. And although this study, with though a small sample size, said that a total shoulder had a greater failure rate, whereas a hemiarthroplasty is almost 90% of the arthroplasties lasted through time. So, what are the indications really? When do you do a total shoulder arthroplasty? Is when you have a concentric glenoid wear, where putting in hemiarthroplasty is still going to give that glenoid concavity and reduced pain because of reduced wear on the glenoid side. And a younger patient with a avascular necrosis of the humeral head, where the glenoid is not really affected. So these are your two patients where, or two indications where you consider a hemiarthroplasty with a resurfacing. But doing a resurfacing is like parking a car in a tight space like this. It's challenging because if you go wrong, you can cause overstuffing, where the where and which can lead to rotator cuff failures and cause of pain. There are two ways of reducing this overstuffing or avoiding this overstuffing is use smaller head sizes of the two that you measure and avoiding varus. If your implant is in valgus, you're going to have overstuffing. So what was the reason of stemless coming in when resurfacing was so good? The reason for having a stemless is that you have better access to the glenoid. And there is a good 3D finite study done on modeling saying that actually resurfacing causes less bone resorption than doing a hemiarthroplasty. So really comparing both of them, a stemless wins because it has all the advantages of a resurfacing. Why do you now need a stem at all then in these patients? Because when you do a stemless arthroplasty, you are reducing the amount of blood loss, reducing OR time, and it's shown in published literature as you see over here that you're going to have better range of motion and better function, reduced radiolucencies, less stress shielding, and all of those. But there are some considerations. Do not throw your stemmed implants away because there are some considerations where there is severe osteoporosis, there is weak proximal humerus metaphysis, where your fixation can fail if you do a stemless arthroplasty. A simple thumb rule is that if your thumb can insert into the metaphyseal bone, then the bone is too weak. You probably better off putting in a stem. So yeah, please keep your stems available. Short stems are better because revisions are going to be easier. The other advantage of doing a stem arthroplasty is that it can be part of a convertible system where you can then convert it into a reverse if required. However, in a lot of case studies, and I think Babulkar sir would also tell you that conversions are not very easy. You can have a lot of lengthening in those patients and can be tough. So when you do a stemmed implant, do you do a cemented or a cementless? So there are several advantages of doing it cemented. The advantages are you get good immediate fixation, you can have a smaller stem, and you can still have good fixation. There is better positioning, immediate positioning and hold. And there is a low rate of aseptic loosening with cemented. So what's the disadvantage really? All of these are great advantages, but disadvantage is that if you have to revise it and removing a cemented stem is going to be a hell lot difficult compared to a cementless. So why do you do a uncemented? Because of the same advantages that you can have uh, you can have less. It's less time consuming. You can put it in and still have a greater hold. Now with uncemented implants, you have proximal. I mean, you can have proximal fixations. You can have distal fixations and all of those. But there are some disadvantages as well because there is going to be stress shielding. There is sometimes implant migration, iatrogenic fractures if you don't put it in too tight. So this is example of a metaphyseal fitting implant. That's an example of a diaphyseal fitting implant. And sometimes you can have an an incomplete seating of the implant and which can be proximally proud. This is not what you want. And then there are some times when it's too small and you can have a stem subsidence. So these are some complications of uncemented implants. Head modularity has come in recently where you can recreate the proximal humerus anatomy much better with these modular implants, where it has some dials where you can, even if your stem is put in anteriorly or posteriorly, wherever the best fit you get, you can still have these dials to best suit your proximal humerus anatomy. There are some advances in proximal humerus materials. There are pyrocarbon implants available which have lesser wear rates, and ceramic implants also are known to have lesser wear rates compared to cobalt chromium heads. But does that really translate to better patient outcomes? It still remains to be seen. On the glenoid side as well, there are vitamin E coated polys available. There are ceramic glenoids available. Are they really going to translate into better patient outcomes versus ultra high linked uh, polyethylene? Still remains to be seen. You can have these designs available in the glenoid side. It can be a peg, the keel, and hybrid glenoids now available to achieve better glenoid side fixation. And if you extrapolate it to uh, you know the ideology where you have a metal backed glenoid, that was the original idea was that that as well could be converted, but it was known to fail. There was a lot of backside glenoid wear and it failed. So that design has literally been given up. There are two ways when you try to implant these glenoids, especially in patients who have uh, glenoid wear rates like B2 glenoids and stuff, where you can either do a off-axis reaming or an eccentric reaming to remove the bone and try and make it concentric. But the world is moving away from putting in total shoulders in patients who have excessive glenoid wears, and those patients are going towards reverses. However, there are some advances here on the total shoulder side where there are wedge glenoids available. Studies are still pending, or we still have to see whether these types of augmented glenoids in total shoulders are doing as well as reverse total shoulders in patients. You can definitely bone graft your glenoid defects, but the glenoid is the weak link in a total shoulder. So because the anatomical shoulder will have still have some anteroposterior movement, you can have some off-axis loading of the glenoid implant, which is called as a rocking horse phenomenon, and which is the main cause of failure of the glenoid side. So as you see, for an example on this patient where there is a B2 type of a glenoid, and if there is a total shoulder implanted, you can have a lot of off-axis loading causing failure of the glenoid. As we already discussed, metal back glenoids used to be uh, there, but they failed miserably. And what's new now? So there is something called as an inset or an inlay glenoid in a total shoulder, which biomechanical studies do show that there is less off-axis loading as compared to an on-lay implant, which used to be sitting proud on the glenoid versus these implants which are sitting deep into the glenoid. It's like a resurfacing arthroplasty, for example. And less off-axis loading is going to cause less rocking horse, going to improve longevity of these implants, but they are not yet available here. There are very small studies done on these implants called the ovo glenoids and ovo resurfacing implants by a company in America. And small studies do show that they are also being implanted in B2 and C glenoids, which is called playing it where it lies. So exactly where the glenoid wear is, that's where you put this implant, and it's showing some improvements by these two studies, but they are really small sample size. So long-term studies still awaited. So there is still some hope for total shoulder arthroplasty, but until we are there, the indications of total shoulder arthroplasty in the world are sort of moving a lot more towards reverse total shoulder in patients, even with intact cuff and glenoid arthritis. This slide has been borrowed from Suman Krishnan, and this seems to be the current norm in all over the world. And we see the trends of reverse total shoulder arthroplasty increasing in the world. And as you see that if your patient is less than 50 years of age and they have a concentric glenoid, definitely a hemiarthroplasty would probably do better than a total shoulder considering that the glenoid side is currently failing. In a patient who is 50 to 60 years of age, it's a gray area. We still don't have a correct answer for this age group. You can either, depending on the glenoid wear, you can consider either reverse or a total shoulder arthroplasty. But definitely in patients who are 60 or 65 and above who have a non-concentric glenoid wear, reverse total shoulder arthroplasty seems to be performing better in these patients. Thank you. I hope I threw some light on this topic.